Welcome to the Elizabeth McGowan Training Institute at Morningside Ministry. mmlearn.org's distance learning is proud to offer a 4-module series dealing with behavior problems, dementia, and mental illness in long-term care. These modules are going to address skilled nursing, assisted living, and in some instances you'll even see it applies to residents we serve in independent living. The presenter we're delighted to have is Dr. David Smith, a geriatrician, certified medical director, and author on this subject. And most important to you, he's a great speaker. He's going to hold your attention and bring incredible examples, and he leaves you knowing that he knows what you are dealing with. That's most important. The first module deals with behaviors in dementia, the causes, identifying problems as they relate to admissions, MDS, change of condition. You're going to learn the possible etiologies or causes of dementia and those conditions that might just be masquerading that we can better address. Very important, very interesting in this module are addressing aggression and predictors of violence. This is essential for personnel to watch, and it's a great risk management tool as well, for sure. The second module deals primarily with drug treatment, chemical restraint issues, how marital relationships affect behavior. This is an interesting topic and one we don't often think about. And there's a great overview of the dysfunctional family dynamics and how do behaviors affect the staff and you. In the third module, Dr. Smith reviews and explains testing such as the mini-mental, the slums test, geriatric depression scales, and many others for your review. Pharmacological therapy will be explained in regards to mandated informed consents, and most interesting is the therapeutic windows of drug treatment. The final module talks about activities, and this is great if you have activity coordinators as well as the rest of your staff, and the prevention of mental illness using these activities. You're going to learn a great deal about the environment and non-pharmacologic interventions. These are the interventions we all look for and need in handling these challenging behaviors. Each module lasts approximately 1 hour, and you'll have slides addressing the objectives for each module, and I'm now going to share the required disclosures that we have to give you. So the program that you'll be seeing in 4 different modules is behavior problems, dementia, and mental illness in the long-term care setting. If you have cell phones or pagers or any other distractors, turn those off now so you can actually enjoy the series. As we told you, our presenter is Dr. David Smith. And this is approved for contact hours, and you must take the entire program. You're required to sign in, and you've done that by registering online. You'll be required to complete an evaluation and a post-test at the end of the program. Your evaluation sheet and post-test are required before you can receive your certificate. So now let me share the disclosures quickly with you, but there were no conflicts of interest evident in the development of the content for this activity by the planning committee members or presenters. There's no commercial support that was received by EMTI at Morningside Ministries for the activity. There are no endorsement of products, and there's no off-label use that's related to the content of this activity. What's great about the programming through mmlearn.org is if you want to ask a question or make a comment, you can do that. And if you want to send us an email, just click on the email, and I will tell you that you usually get a response within about 72 hours or shorter. What do you think? We always want to know what you think, and so at the top of your screen you're going to see this request for survey. We ask you to fill those out so that we continue to bring these programs to you. Remember, it takes less than 5 minutes. And the objectives, as I told you, for each program will be listed prior to the start of each module. So thank you very much. Enjoy and let us know what you think. Thank you. Bye-bye.
Thank you for joining us. I am Dr. Dave Smith. I'm a practicing geriatrician up in Brownwood, Texas, and still a professor of family medicine at the Texas A&M College of Medicine, although I don't have a job description and they don't pay me anymore. The topic today will be behavior problems, dementia, and mental illness in long-term care, and we're going to try to cover epidemiology, the causes, the effects, the team process by which we scrutinize these problems, and therapies including both drug and non-drug varieties. First, going to talk about epidemiology. Mental illness in the nursing home can be characterized as being composed by a variety of pathologies. Dementia is certainly the lion's share of our trouble. with about 70% of all nursing home patients suffering some degree of dementia. If we look for all pathologies that we're going to talk about today, it will be a number upwards of 90% of all nursing home residents. This is an incredibly important part of what we do. Behavior problems will occur in about 40% of our residents at any one time period because of these pathologies, and they have a variety of consequences for the elder and for others and for the institution, including problems with declining function, consequential falls, certainly a decrease in the quality of life for the elder, the increased chance that medications will be used, the increased chance that restraints might be utilized. The consequences of mental illness in the nursing home, particularly in regard to depression, and I could have also added delirium here, includes increasing mortality. In the case of depression, I have a sense that the depression actually causes downstream things to occur which then lead to death. So the depression is in fact causing or contributing to death, whereas in the delirium, probably delirium occurs in people who are in some stage of the dying process to some extent, and so is not cause, but rather a fellow traveler. In regard to dementia, of course, the big player epidemiologically is Alzheimer's disease, with 70% of those 70% who are demented suffering with Alzheimer's. If we look across all elderly, those both inside and outside of long-term care, there were 4 million persons with Alzheimer's disease in 1996, and that's projected to rise to 12 million people by mid-century. And clearly, if we continue to care for folks in the same fashion we have now, the costs to them on a humanitarian basis as well as to us as a society on a financial basis are staggering. I've got a slide here, PASSAR, because when the state mental hospitals across the country were deinstitutionalized, the number of residents there was decreased exponentially in the 60s and 70s. The fear on the part of particularly the state mental health program directors around the United States was that these people would transition out of state mental hospitals and then just get placed in nursing homes. And in fact, that did occur to some extent, and I don't think any of us lack having 1 or 2 or 3 residents at least who are chronically mentally ill, many of them actually younger people, or those with mental retardation who need care that cannot be found in the community. So a periodic and systematic annual resident review program was designed to be sure that people with mental health needs were not placed incorrectly into nursing homes where their mental health needs might not be properly served. What's the reason for the bull? Oh, well, that's my editorializing on the issue that maybe PASSAR has performed about as usefully as teats upon a bull. But I won't be quite that harsh. There is value to the program, but it didn't do really what we needed it to do. And I think if we're honest with ourselves, mental health care in the nursing home is by and large lacking in its quality and availability, such that these problems are tremendous problems for us all. A little bit of a task. I'd like you just mentally ask yourself then, from what you've heard so far and from what you know as an experienced caregiver, what percent of people in the nursing home residents suffer dementia? If you're thinking 70%, that's correct. What percent of elderly in the nursing home suffer from depression, major depressive disorder, or have depressive symptomatology? If you answered 30%, you're pretty close to right. That's what the literature is expressing. How about psychosis in dementia patients? Those people with dementias, how many of them have hallucinations or delusions? Well, that number is about 10%. What percent of people would have experienced physical or mental or sexual abuse earlier in their lives and are now residents of nursing homes? Important to know, about 10%. What percent of folks in the nursing home are suffering from a delirium, a fluctuating, global impairment of their cognition? Well, that number is not really known, but what we do know is that about 50% of elders who present from a nursing home to the emergency room or to a hospital are suffering delirium when they get there. Now, those are the folks that are acutely ill enough to have gone to hospital, and that changes the number, so the number surely is not 50% back there at the Songbird Lodge, but it's going to be high because we're seeing that tip of the iceberg when they're in the hospital. What percentage of people have bipolar illness or cyclothymia in the nursing home? How often do you see that diagnosis on your charts? Well, we don't know. This is another number we don't know. If we take the percentage of the whole population that suffers from this kind of a problem, you know, it's down there in the 5 to 10% category. And so where are they when they are now nursing home residents? We certainly don't have that diagnosis on the chart very often. Same thing about personality disorder. Any idea? I don't have one. I wish we did. What percent of nursing home residents have personality disorder? Again, in the whole society, that's a significant percentage, somewhere around 5% or more. That suffer from antisocial personality, borderline personality, obsessive-compulsive disorder, are hysterical, etc., or have a mixed personality disorder. Now, it's my impression or my concern that actually this number may be distorted and overrepresented in the nursing home crowd. Although it would tend to be underrepresented in the nursing home crowd because people with personality disorders, particularly things like borderline and antisocial, oftentimes do not have good health behaviors, lead a chaotic lifestyle, have accidents, have deaths with violence, don't take good care of themselves because of physical diseases, and may perish before they reach nursing home age, vulnerability. And yet, the other dynamic that's going on that I think is even more important is that folks with personality disorders may not develop enduring relationships, so that they don't have family and friends to call upon when they become infirm and need care in old age, and so they end up in the nursing home more often than those who do not have a personality disorder. And if we can go back to something that was on a previous slide, then what percent of nursing home population have some diagnosable psychiatric or psychological problem? Well, Barry Rovner back at Duke University did a prospective study using trained and board-certified psychiatrists to actually go in and do examinations of each and every resident in the study nursing homes, and found that that number was upwards of 90%. That number corroborates a couple of descriptive studies that were done previously, not with actual exams, but with chart review, looking for diagnoses, looking for behavior problems, looking for other markers of psychiatric or psychological problems in the nursing home residents that came up with numbers that were basically the same, upwards of 90%. And so that tells me something as a doc who's been involved in long-term care for some 35 years, that nursing homes aren't really nursing homes. Nursing homes are partly a long-term rehabilitation hospital. That's a different lecture, a different day. This is about the 50% of admissions who are folks that come in after they broke their hip and they can't do the 3 hours of therapy that's required for them to stay in the hospital or be in an acute rehab hospital to rehab from their broke hip. So they come to the nursing home where they can do it at a slower pace. And that does usually comes in around 50% of our admissions. But those are shorter stayers. The other 50% of admissions, but the longer stayers, so a larger percentage of the whole population, are those who have dementia and other psychiatric or psychological problems along with their medical comorbidities. And therefore, that part of what we call a nursing home is actually a long-term geropsychiatry hospital. And yet, have we really resourced this institution to perform this particular task? Identifying problems. How do the problems of mental illness and dementia reach our awareness and the awareness of the attending physician? Well, many times this is right up front at admission, and from the history, from the family who are introducing the resident to the long-term care environment, we learn, why did you have to come here? And it turns out that behavior problems associated with dementia is the #1 real reason for admission to nursing home. There's a close second. #2 is urinary incontinence. But #1 is, in fact, behavior with dementia. Another way that the attending physician becomes aware of this is from a telephone call from the nursing facility staff to the doc, because there's a behavior that's in their face at the current time. That is an acute problem. And we have to be aware of that. We have to deal with it. It does create some challenges we'll talk about later. A final way that I think we aren't utilizing often enough is to rely upon the MDS, and the new version of that is the 3.0, the CAAs and the change in condition issues that are built into that whole process, so that when various things trigger on this instrument, tell us that the resident has or is highly likely to have a dementia or a psychiatric or psychological problem, that will move to the forefront for assessment and potentially for treatment. It's important to recognize that the admissions and the telephone calls are likely to uncover those behavior problems that are, in fact, in our face or in somebody's face, causing a trouble for somebody else. And I think that's why we need the MDS process, and particularly the 3.0, which comes from resident interview in a lot of ways, because this other mechanism helps us find those residents who are suffering with dementia and mental illness who aren't causing anybody else any problem, but they're causing a problem for themselves, either in terms of apathy, amotivational state, reclusiveness, that kind of thing, failure to take good food and fluids, and so forth, that it wouldn't necessarily trigger somebody else to do something about it because it's causing the caregiver a problem. And that's why these things work well together to find all of the problems and get them all handled. Now, I've offered a mnemonic to help us recall the many possible etiologies of dementia, masquerading conditions that look like dementia that aren't. The D can stand for drugs and toxins. And that's kind of fortuitous that that's the first letter of the word, because drugs and toxins are generally the most likely remedial cause for cognitive embarrassment that might otherwise be thought to be dementia or senility when it actually could be fixed. Let's remember alcohol. I try to remember alcohol at 5 o'clock, but not in excess. Environmental deprivation, eyes and ears, is the E, and we need to recognize that when there is environmental deprivation, blindness or extreme problems with hearing, that this can contribute to cognitive decline or masquerade as cognitive decline. Metabolic and endocrine disorders are possible to masquerade as dementia. Things like hypothyroidism or hypercalcemia can lead to conditions that are potentially remedial, and boy, you love it when you can find one of these cases and fix it. Now, the next E stands for emotional, and let me do delirium first. Delirium is a fluctuating Cognitive embarrassment, it's not the same all the time. It comes as an agitated version and a sedated version, or a mixed version where you see both features. It is a global impairment of cognition, similar to dementia. The difference being that in delirium, the delirious patient has an abnormality of attention. You sit down and try to question the delirious patient, and they try to focus on you, but then they're off into la-la land. Or you can't get their attention at all. You cannot get them to pay attention to you to answer a question. Or they'll have trouble with maintaining focus and might return to a past subject. So you've moved on to a new subject, but they're still locked into the previous subject. Those are all features of the delirium. Depression, you're all well aware of, and that this can, in some cases, be so profound that it masquerades as dementia, and that's actually been given the name pseudo-dementia, where the person really doesn't have cognitive embarrassment, but they're not trying to perform on the mini-mental status exam or the SLUMS test. Nutritional deficiencies can lead to cognitive embarrassment, and sometimes that's remedial and sometimes it isn't. B12 deficiency can cause a dementia-like syndrome even in the absence of anemia, so don't neglect to check this in virtually all cases, even if the person isn't anemic, certainly if they are and have a macrocytic anemia. Thiamine deficiency, which is often associated with chronic alcoholism, and pellagra would be other causes. Sometimes it's just general malnutrition, and that, in my experience, has not been a cause of dementia as a sole cause, but what we do see is people that have dementia, and then they're worse off than they would have to be because they are generally malnourished. You get them in the nursing home or into daycare, and they get fed up for a few months, and all of a sudden they're looking a lot better in terms of their cognition. Well, that's what happened. You fed them. Tumors and trauma could cause this, subdural hematomas, and remember that when you fall down and bonk your head, it may give you amnesia to the event, so you're not likely to get a history that the patient has bonked their head. You need to look for it, and there's argument among dementia experts whether we should do an imaging like a CT scan or an MRI on every patient. I happen to be in the camp that I like to see a CT on every patient because of this. And I don't think that you can find those patients by history, and certainly not by physical examination, without that imaging. The cost of the imaging, particularly if you use just a plain CT, is just a few $100s, which is pale compared to a year's residence in long-term care. So I think very worth it. Now, the I stands for infections, and in some parts of the world, human immunodeficiency virus, HIV, is the most common cause of dementia, so for instance, in sub-Saharan Africa. Syphilis used to be a big issue, much more rare now, thank heavens. And then we occasionally encounter the rare entity of Creutzfeldt-Jakob disease as an infection that can masquerade, or that can cause a dementing illness. The A then stands for Alzheimer's disease, but also for atherosclerosis with multi-infarct dementia and the other varieties of atherosclerotic or vascular dementia. Alzheimer's disease is actually a grouping in some ways because it's not all the same. Dementia with Lewy bodies is a condition that may actually account for 10 to 20% of what we currently are diagnosing as Alzheimer's disease if we were a little more discriminating in our diagnostic criteria. Lewy bodies are little subcellular particles that can be found in Parkinson's disease, and they're also found in other dementias, and particularly are prevalent in dementia with Lewy bodies. Dementia with Lewy bodies looks pretty much like Alzheimer's, except that there are early affective changes, particularly depression. Before the dementia is very profound, you can see psychosis, particularly vivid visual hallucinations. And those hallucinations are usually not very don't have a lot of emotional content. They don't bother the person very much. They see goats out in the backyard that really aren't there, or little kids bouncing on the bed that aren't there. And it just doesn't have a lot of paranoid quality or other distressing qualities to it. Dementia with Lewy bodies patients also have a thing called neuroleptic sensitivity syndrome. And since they do have psychosis early in the disease, it is not unusual for some caregiver to go ahead and prescribe them an antipsychotic. Now, the atypical antipsychotics don't seem to cause them a lot of problem, but the old typical antipsychotics, prototype in the nursing home being Haldol, which is commonly used, are extremely toxic in these individuals, and they will just really go south on you and deteriorate, and perhaps even fatally so, when they are given a typical neuroleptic, a neuroleptic sensitivity syndrome. This can be quite diagnostic. The dementia with Lewy bodies has a more profound cholinergic deficit than the Alzheimer's disease, and it's felt that these people actually do a little better with medication treatment than the Alzheimer's patients do. But that's not exactly proven. Parkinson's disease with dementia looks a lot like dementia with Lewy bodies, except in Lewy bodies, the dementia happens first, and then later on the Parkinsonian features come along. Again, with dementia with Lewy bodies, the Parkinsonian features are not so much the tremor as they are the mask-like facies, the bradykinesia, the slow body movements, the postural instability, some of those features of the dementia. With Parkinson's disease, if you have that expression of the Parkinson's disease for a couple of years before you develop the dementia, then it's more appropriately called Parkinson's disease with dementia. Some dementologists are starting to combine these two and not do a separation and calling this Lewy body dementia and just lumping these two entities together. Frontotemporal dementia includes a grouping of diseases, Pick's disease, the most common of these, with a lot more language problems than you would see with your Alzheimer's patients. And supranuclear palsy would be yet another variety of this kind of dementia. Now, vascular dementias account for about 20% of the dementias that we see in the nursing home or in the community, and come in various forms or various etiologies. One is multi-infarct dementia, where multiple little lacunar infarcts nail the brain in so-called silent areas, so that you don't see the paresthesia the paralysis or hemiplegia or the droopy face or the language problems necessarily with this, but you get this accumulation of effects from multiple small infarcts that gives you a picture that is essentially indistinguishable from your Alzheimer's patients. A strategic single infarct type of dementia is clearly somebody that's had a major stroke. Maybe they do have the neurologic impairments of that single infarct. And then additionally, there's been enough brain that's been wiped out in enough of the cognitive areas that they also suffer from dementia. Multiple lacunar infarcts. Binswanger's disease is a vascular dementia of this type that is hereditary, runs in certain families. You can get a dementia after hemorrhagic cerebral vascular accident, a bleed into the brain, and there are a variety of genetic arteriolopathies which are caused by inflammation of the arteries or arterioles in the brain, leading to dementia. To make the list even longer, I mentioned previously the HIV-related dementia. There is Huntington's disease, which is an autosomal recessive familial disease. Creutzfeldt-Jakob disease, or if you come from the other university, that is Jacob-Creutzfeldt's disease. Whoever gets to be first with this comes in several variations. This is the thing you read about. It's very rare, but we read about it, and it is similar to what we see in the bovine species, and this is mad cow disease. Don't confuse this with PMS. That's a whole other thing. Okay? Normal pressure hydrocephalus is an entity where, even in Alzheimer's disease, you get hydrocephalus ex vacuo. The ventricles enlarge, the sulci get bigger, the brain is shrinking. But in normal pressure hydrocephalus, the ventricles are actually pushing out and filling up and get large that way, as opposed to the brain shrinking and therefore the ventricles getting large. In normal pressure hydrocephalus, a triad of symptoms has been described with the dementia, with gait disturbance, and with incontinence, urinary incontinence. Trouble is, our dementia patients with any of the causes tend to have that collection of symptomatology, so the triad is not very helpful from a diagnostic standpoint. When you find this, and it's found with imaging, maybe on the basis of your suspicions, but when you find this, referral of the patient to a facility where there is a great deal of experience in shunting to determine who will benefit by a shunt and who will not. But ventricular abdominal shunting has been used and is helpful in maybe about 50% of the patients. Now I'm shifting gears here. I want to move on to looking at the behaviors themselves in their utility for being diagnostic markers. And I want to show you that Dr. Mega has a table here, and this is a very renowned and credible researcher who has opined on these subjects for many years, but I'm going to beat him up a little bit in this lecture because we have a table here that lists a variety of behavioral disturbances that are found in Alzheimer's disease and percentage of those. And we've got apathy, and we've got agitation, anxiety, verbal aggressiveness, irritability, so forth and so on. Now, hallucinations is a pretty good, delusions are pretty good descriptions of a behavior that I think have some diagnostic utility, because those kind of go with certain diseases, although they go with a lot of diseases and don't help you hone in on an exact cause. But if you take a word like agitation, what does that really mean? And if we go through these other, verbal aggressiveness, what does that really mean? And are we really cataloging a grouping of behaviors that have widely different meaning and therefore potentially widely different causes? So why did we do this? Just to show you that Dr. Mega is not the only one, this is a professional acquaintance of mine, Pierre Thériault, who is also quite renowned and a very credible researcher. And I'm just going to beat him up a little bit on this kind of a slide, the same thing, with a listing of behaviors and an epidemiology attached to those. Look down the middle of that and you see socially objectionable. What does that mean? Do they spit on the floor? Or do they say four-letter words in public? Or what exactly does that mean? And if it doesn't mean anything in terms of what disease might be causing that, or what disease or condition might be causing this, how can it be useful really to look at it? I developed a list that I wish you'd take a look at that I think does have it kind of covers the array and gets us talking in common language. And yet I still don't want you to use these as a kickoff to diagnosis. We'll talk about that some more. But people can be assaultive. Assaultive means that they actually seek out somebody to whack on, okay? As opposed to combative, and combative is not that the person is perpetrating, but they hit when they are approached, when somebody else is trying to do something in their space. Delusions, which can be simple or complex delusions, it may take the form of false accusations, are possible. Hallucinations can be auditory, something the patient heard that isn't really there. can be visual, something the patient saw that isn't really there, or global. The patient is sitting in the day room and believes that they're in their living room. They just got it wrong. And it's not just a thing they're seeing, but the entire environment is misperceived. Hoarding, of course, you've seen the TV shows now on HBO, not HBO, on the satellite TV about the hoarders, people that save every dirty napkin and fold it up and stack it up by their bed and so forth. Some people are, in fact, homicidal. They're trying to kill somebody. They may be non-compliant with medical care. Another version of that, you might use the word non-adherent. It might actually be more appropriate to say non-adherent, because non-adherent doesn't imply necessarily that the patient is wrong and the caregiver is right. A person might not be taking the medicine you gave them because it isn't good for them and they know it isn't. Pacing. Pacing is going back and forth repetitively with no place to go. We'll get to other forms of locomotion in a minute. Pestering or unreasonable demands is just what it says, and I know you've experienced that. Some patients are reclusive. They want to hang out by themselves and don't want anybody else around. Some residents, patients, have sexually inappropriate behaviors, and I want to break that down into those who have an appropriate agenda, but an inappropriate manifestation of it, and those who have an inappropriate agenda. There may be suicidal patients, and this can be active attempts to kill themselves, or passive in that they want to die, and so they are not eating, not drinking, not moving around, staying in bed all the time, reclusive, and cocooning in order to die. Verbal abusiveness, I know if you've experienced, you know what we're talking about there. Now here's the other motor issue, and that is different from pacing. We've got wandering, and wandering can be of an agenda type where the person is trying to go out of the facility, or they're looking for their keys that they lost 8 years ago. I had one guy that was looking for his keys for 8 years. We tried to get him a set of keys, and we showed them to him. He said, no, those aren't mine, and continued to look for his keys. You can have shadow wanderers who trail around by the nurse because they feel insecure when they're alone, and they just hang on the nurse because that nurse gives them a little security. And there's aimless wanderers who just drift around without an agenda here and there and get into everybody else's stuff and get into trouble. So, and I picked on agitation here, but we could do this with most of the words that we've used. Agitation, what does this mean? And I frequently see orders written for PRN medicines for agitation. And I'm not sure what it is. We wouldn't allow that for that kind of lack of clarity for other medical orders. What does it mean, agitation? Are they pacing? Are they verbally shouting out? Are they pounding on the tray table? What? And so I think we need to get more precise and know what we're talking about. Cohen-Mansfield has done a whole literature to try to give some meaning to this word agitation, and I think in a research venue that's appropriate. But I think this is a very scary word when we use it in everyday clinical geriatrics. And the point I'm really trying to make with all of this is that no psychiatric symptom is the sine qua non of any psychiatric disorder. I didn't say that, I just repeated it. The guy that said it was R.C.W. Hall. What do we mean by this? If I could pick out crying, does crying mean that people are depressed? Karen, do people cry when they're depressed? Well, yeah, they do. But some people that are depressed don't cry. And do people ever cry for other reasons than depression? Yeah, they might be in pain. They might be frustrated. They might even be at a wedding and be happy. So the symptom of crying does not tell us that the patient has the disease major depressive disorder. There are just many ways to skin a cat, and this is true of the psychiatric symptomatology as well. When we use a behavior this way, it can be a useful construct for epidemiologic purposes and planning. X number of dementia patients have these kinds of behaviors. Therefore, we've got to staff to do this. We've got to provide resources to handle these problems. That's the epidemiologic use. But it's not particularly useful for the evaluation and treatment of an individual resident, because you don't really know what that symptom is being caused by. The symptom doesn't give you a very good clue. And we need to get away from doing that, and we certainly can't use the behavior to dictate treatment. Behaviors are very individualized. They're unique, and they're even dynamic, so that a behavior is not exactly the same in the same resident every time it occurs, because it's colored by other things that are happening around them. The elder who is assaultive may get up and clean the clock of a resident who they perceive as smaller than they are, and become verbally abusive, but not punch another resident that they look at, and they're looking up at him this way because they are still cognitively intact enough to know that if I clock that guy, he's going to clock me back worse. So the behavior is dynamic and shaped by what's around it, and usually is a mixture of multiple factors. The behavior alone does not predict the cause, and therefore the behavior doesn't dictate the treatment. And this is a very subtle thing, but it's one of the key messages in my talk here, that we need to get away from thinking of the treatment goal. Minnie is being combative with the aid staff when they take her to shower. My goal is not to make her non-combative with showering. If I do that, I have jumped over an essential part of the process, which is what causes her to be that way. If I want Minnie not to be combative with showers, I can solve the problem every time, very simply, with no thought process. All I need to do is put her in a straitjacket and take her to the shower. Okay? But that's not what we do, except maybe when we use chemical restraint as our only armamentarium for extinguishing a problem behavior, a behavior that's a problem for us. But we leave that patient's problem unsolved, and therefore their suffering and their decreased quality of life hasn't been addressed. So the behavior doesn't dictate the treatment. You must diagnose before you can treat. Rasputin, the mad monk of Russia, told the royalty of Russia at that time that you must sin before you can repent. And it's pretty hard to argue with that, and that's a motto by which I've always tried to lead my life. But it's also true that you must diagnose before you treat. Some things just have to be before the cart. The horse must be before the cart. So symptomatic treatment, which I think we see rampantly in our environment. Symptomatic treatment, meant simply to give a drug to extinguish a behavior, is chemical restraint. And we don't do that. That's not appropriate. Unless, two escape clauses, and this is in OBRA 87, the original version. I think it's been transmuted into the newer version. That chemical restraint is appropriate as a temporary intervention until you can get your resources together to have a team meeting, to do evaluations, to do whatever is necessary to find out what is the root cause or causes the behavior, and what can we do about the causes that will then, as a consequence, as a secondary benefit, prevent the behavior from the problem behavior from occurring. The other place to use chemical restraint is with a predictable problem under a certain stimulus. So if a resident who's quite demented is requiring dental work, and every time they get to the dentist they try to scratch the dentist and get all agitated and might hurt themselves, I think it's appropriate to temporarily use chemical restraint. An Ativan, a half an hour or an hour before the dental chair, so that they can enjoy that dental experience. view with suspicion all orders for as-needed PRN antipsychotics and anxiolytics. PRN antipsychotics would imply that you're not trying to get a blood level or a tissue level in the brain. And that means that you're taking a drug with a pleiotropic activity on dopamine and other neurotransmitter systems, and all you're enjoying from it is the sedation. So why would a person do that? You might as well use just a sedative drug. And anxiolytics, if you're not treating chronic or extended periods of anxiety, then all you're getting from it is sedation. And if it's sedation, is it chemical restraint? And the answer is not always, but probably. Usual and customary practice, and I'll point out to you that the reference for this particular slide is 1988. That's 23 years ago. And I want to ask yourself if this is still our experience in long-term care today. Sloan and Leake and Ruckledge did a study of 2 nursing homes and found that 7% of the telephone calls from the nursing staff to the doctors, to the attendings, were about behavior problems and involved the prescription over the phone of psychotropic medications of one kind or another. Of those 42 calls that were evaluated, only 4 resulted in a later physician visit within the next 3 days to evaluate what they had done on the phone at the bedside, to do an assessment and to decide whether they were actually treating a neurochemical problem or are we just putting a Band-Aid on the behavior. And I'm afraid that this is still the case today. This is also a really old slide, but the more things change, the more they stay the same. I was asked, and Aricept, I think, is reaching at the end of its patent life, donepezil. I was asked by the Pfizer company to go out to the wine country out in California and talk to the marketing group and the science department of Pfizer in this area on the subject that they gave me is, why don't all Alzheimer's patients behave the same? If they've all got Alzheimer's disease, why don't their behavioral symptoms all look the same? And so as noxious of a task as it was to get on a plane and go out to Napa Valley and drink wine and talk to these folks, I did it. Yeah, I mean, you got to suck it up. You got to do even these hard jobs. And what I told them then was the same thing I am telling you now. And we could replace the letters AD for Alzheimer's disease here with dementia, because this is true for all of the dementias. That some of the factors that are all working together to cause a behavior, and we're talking about maladaptive behaviors here, in a dementia patient are these. First of all, there's the level of the cognition. Some of these folks have mild dementia, some are moderate, some are severe. And so that, where they are on that dementia history makes a difference to what kind of behaviors we're going to see and how the behaviors will unfold. Going counterclockwise, the next factor that I can think of is psychiatric comorbidity. So if you've got a dementia patient who has suffered from obsessive compulsive personality disorder all of their lives, and was a hoarder or was overly regimented and a hand washer, their cognition is no longer there to kind of keep those problem behaviors in check. And the problem, that OC actually gets a lot worse because cognition isn't there to put a little bit of reason into it. If they have depression that's been recurrent all through younger life, and now they got dementia and depression, the two pathologies work in concert to shape the behavior and make a worse result. Continuing counterclockwise, I think we could postulate that there probably is a variability in the pattern of neurochemical and anatomical defects. from one patient to another. I don't think every Alzheimer's patient has the same amount of cellular or neurochemical pathology in every region of the brain. There's some variation in there that might explain some of the differences in their behavior. Continuing on, the milieu. Now, the milieu is the environment we create in long-term care or in day care, and it's everything in there. It's the architecture, the layout of the place, it's the colors of the walls and the pattern on the rug, and it's the ambient noise, but it's also more complex things like the attitudes and caregiving habit patterns of the staff, whether staff give choices and are respectful to the elder, or are they demanding and regimented and force the elder into their agendas. Those are some of the kind of things that will affect the resident's behavior when they have dementia. Premorbid personality makes a difference. You know, I'm fond of saying that everybody is normal until you get to know them, because we all have our quirks, and our quirks are what make us who we are. But when we have dementia and can no longer keep control of our quirks, then sometimes these come to the forefront and become quite problematic. Health status makes a difference. If a resident is robust and strong and has a good walking speed, a whole different set of possible behaviors than some fellow that is diabetic and is a double leg amputee. That double leg amputee gets demented and he gets depressed, and he gets crabby with that depression, and he may have some noxious behaviors, but he's not going to kick anybody because he can't. And he can argue with you, Karen, but he doesn't have a leg to stand on. Extrinsic adaptive resources. What do I mean by that? This means it's better to be rich and get dementia than it is to be poor and get dementia. It's what resources do you have and do your loved ones and your caregivers have to benefit you in your disease. Coping skills, finally coping skills. And we all have historically active coping skills. We have those habits or cultural tactics that we use when we approach problems. As an example, some of us, many of us who are in the sciences and caregiving especially, are analyzers and will tackle a problem, let's say behavior troubles in a teenage kid, by analyzing it and cutting it apart and looking at the separate parts and figuring out how can we fix this particular problem. Whereas other people might be sublimators and choose to cope with the problem by sublimating it, by sticking their head in the sand. You remember Scarlett O'Hara from Gone with the Wind? At the end of the Civil War, Tara is in ruins, and the camera pans to her, and she's standing on a hillside there on her beloved Tara with the sun going down behind her, and she's thinking of all this disaster and all the problems before her, and she says, "I'll think of that tomorrow." And she's a sublimator. Now, those of us that are intellectualizers, analyzers, don't think very highly of sublimators. That's no way to go through life. But think about it. If we get dementia, our main coping skill is shot. It's ruinated. Whereas Scarlett O'Hara's historical coping skill is operational. It still works for her. She can just bury her problems even in dementia. So what coping, and the coping skills talk is like a whole nother day, so we can't get into all of it, but you get the sense of how this works, that how people tackle problems and to what extent cognition plays a part in that makes a big difference. Well, let's transition on to the causes of behavior problems in long-term care. Behavior can be looked at as a disease-oriented conceptual model. That is, the patient has Alzheimer's, acetylcholine in their brain is deficient, and so they can't properly understand this, that, or the other thing, and therefore the behavior. Or it could be considered on a social systems conceptual model. The Alzheimer's patient is a retired postman. It's no wonder he wants to get up and try to leave the facility at 5 in the morning. Other explanations for behavior in the demented, and particularly the non-communicative resident, would be those with an appropriate agenda but inadequate cognition to carry out that agenda. Fatigue, fear, discomfort, pain, being cold, having an unmet physical need. Turns out, in my experience, that the most common cause of behavior problems in dementia patients, most common cause of agitation, violence, aggression, assault, resistiveness, are misinterpretations of reality due to the cognitive deficit. We encounter a significant amount of aggression. This is a big problem. It puts us at legal risk. It puts us at regulatory risk, and it certainly puts the resident themselves and other residents at risk for injury, and deserves our attention. It is more often found in those with moderate to severe dementia. It may be caused or contributed to by territoriality. Most of us have a certain amount of territoriality, and certainly elderly men are very likely to show this. Male-to-male dominance may be a factor. Psychosis, especially if there is paranoia. The paranoid person may strike out of fear because they want to preempt somebody else hurting them. They're actually worried that they're going to be hurt, and so they're violent in order to preempt it. Pain makes us all crabby, and if you can't communicate that, then it may exemplify or return to aggressiveness from that patient. I recently had a little sparrow of a woman, a Hispanic woman, who was quite severely demented, who came to our behavioral unit and was wandering around the unit aimlessly, and from time to time would get in the proximity of this resident or that resident, and a lot of times she'd just kind of bump into them like a bumper car and then move on down the hallway, but other times she would go ahead and clock them. And the gals were at their wits' end and wanted me to do something about it, and actually she was admitted to somebody else, and I went and saw her, and I did a physical exam, and I found out she had a grade 4 uterine descensus. Her uterus was, she'd had 5 kids, and they were big or came out sideways or something, and the uterus was just down around her knees. And I reasoned that perhaps this was uncomfortable, and that in her dementia she wasn't able to localize this or know the cause, and it made her crabby, and that she would strike out at others. And so we did an analgesic trial. I put her on a Vicodin 500 once every 4 hours on a scheduled basis while awake. And lo and behold, the assaultive episodes reduced. Not extinguished, but they reduced. And I took her up to 7.5, and they basically extinguished. And with that information, even though her dementia was pretty bad, and even though her lifespan was pretty short, we called the GYN surgeon and had her go to surgery, and she underwent a vaginal hysterectomy, pretty big operation. But she came out of it, recovered, and no longer needs pain medicine, and is happily wandering aimlessly around the unit without being assaultive to anybody. Frustration, irritation, anxiety can do this, depression can do this, and certainly bipolar can do this, and we don't always get the history that the patient has been bipolar. In fact, a large number of us are bipolar or cyclothymic and make it all the way through life because we are pretty smart and we know how far we can go before we get into trouble, so we don't go any farther, and we never kind of get into trouble enough to get the diagnosis. But then along comes dementia, you're disinhibited, and out comes bipolar characteristics and resultant behavior. Aggression in dementia can be caused by infections, head trauma, pain and discomfort we already mentioned, worsening of a medical illness that we already knew about, congestive heart failure, dyspnea with COPD, the development of a new illness, a developing hyperparathyroidism or something. Or it can happen with a change in the environment, changing from room to room or from hospital to nursing home or from nursing home to hospital, etc. It can occur when there are new people in the resident's life, problems with sleep, worsening of the dementia. They may have had a milestone in their cognitive embarrassment, the development of delirium, and we always need to look for medication causes. I kind of smile every once in a while. I get the chance with a new admission, somebody that's I have not had before, and in they'll come with these horrendous behavior problems, delusional or hallucinating, and combative and flying off the handle, and nobody can handle them. And I look through the medication regime, and 6 months before some neurologist or somebody has started the patient on, let's say, Mirapax for restless leg syndrome. Well, Mirapax is a dopamine agonist, and after a period of time it may build up to where excessive dopamine is going to cause psychosis, and I take it away and the patient gets normal again, and it happens in a few days, and you know, you can really be a big hero. It's very gratifying. Predictors of violence in dementia patients. This is important, and when I do Adult Protective Services work, I rely on this quite heavily to tell me how dangerous is this person to themselves or others should they have a forced removal from their home or have a guardian, etc. Should they receive forced psychiatric medications under a court order. Predictors of violence in dementia patients would include a past history of physical or sexual abuse as a victim. Victims often become perpetrators. Brain injury with disinhibition of the frontal lobe. Frontal lobe is where our manners are, where our checks and balances are, and if that's not there, people may be violent. Paranoia, as I said before, because they will preempt violence on those who they fear are going to harm them. Physical strength, mobility, and speed are not really predictors of violence, but they're predictors of how significant the violence will be. But don't kid yourself. A little 90-year-old lady who weighs 80 pounds soaking wet can hurt you when she sticks her finger in your eye. So it's reasonable to worry more about the 220-pound ex-boxer than it is that little old lady, but don't take it as an all or none. Opportunity makes a difference, and weapons make a difference. When I'm doing the outpatient arena and doing APS work, I'm checking to see, do they own a gun? Do they own other weapons? And do they have ammo? And these things are important predictors. If somebody's delusional and threatening to shoot you, but they don't own a gun, it's not nearly as scary as if they do, not nearly as scary as if the gun is loaded. It's not nearly as scary as if the gun is in their hand.